Welcome to the Benefits Executive Roundtable, hosted by Dorothy Cociu, President of Advanced Benefit Consulting. Dorothy is a nationally recognized benefits and compliance consultant and group health broker. Here, you will watch and listen to industry experts who will break down the latest trends in employee benefits, healthcare reform, state and federal legislative and regulatory activities, all designed to empower executive decisions. We are proud to bring to you all new for Season 6 video podcasts. We hope that you enjoy your new video podcast format, and please forgive any audio or video imperfections. Thank you for viewing and listening.
Welcome to the Benefits Executive Roundtable. I'm your host, Dorothy Cociu, President of Advanced Benefit Consulting. And I want to welcome my guest today, Maggie Stedt of Stedt Insurance, who's a Medicare expert, past president of the California Agents and Health Insurance Professionals KHIP, past president of KHIP Orange County, as well as a Medicare advisor, task force emeritus member for the National Association of Benefits and Insurance Professionals, and just a great person overall. Known Maggie for many, many years. Welcome back, Maggie, and thanks for joining me again for this first season of video podcasts.
Well, I really appreciate you asking me to be on board today because there's so much information to share, and any way I can help your clients and friends just to know what's happening, because it is a wild time. I will tell you, this is going to be one of the craziest open enrollments we've had in a long time.
Oh, well, thank you for that. And it's not just my clients and friends that, listen to our podcast and now hopefully will be watching our podcast. We have a very wide, diverse audience from human resources people all over, CFOs, CEOs, industry personnel, and then just consumers. So we have a very, very wide and diverse audience. So thank you again. I'm sure they're going to really, really appreciate all of this great information that you share with us pretty much every season now for the last several seasons. So thank you for that. You're a regular. We can just call you a podcast regular. So anyway, let's get started. I understand that there are a lot of new rules, as you mentioned as well, for agents selling Medicare plans as usual. But also there's been a lot of controversy, frustration, and shall I say despair related to compensation. Well, let's start with the basics because, we always do this because there are audience members that may be listening or watching today that may not have participated in listening to our past podcasts, which we kind of talked about some of these things. We do it every year. So for those reasons, I want to go back to some of the basics again. The Medicare plan options that are available to Medicare enrollees are vitally important, because obviously it affects the type of coverage and the type of care that they're going to receive in 2025, which we all care about. What would you say are the most important things that consumers need to know if they want to help their family, their friends, and anyone else who's age 65 or older and eligible for Medicare?
Well, I think the biggest change due to the Inflation Reduction Act from 2022 is the change in the prescription drug area. And so the best news about it is that the donut hole has gone away. So for those of you who are not familiar with that, in Medicare world, we had several stages. We had where there was a deductible, then we had the initial phase of the plan where we paid the individual paid co-pays or co-insurance up to $5,030 this year. And then they went into the donut hole where when the total expenses, what they paid and the company paid, reaches $8,000, then they go into catastrophic coverage. And this year in 2024, catastrophic coverage went to 0 instead of 5%. Well, this coming year in 2025, we'll have a deductible. It'll be $590. And the plans can either do the co-pays or co-insurance amounts up to a maximum of $2,000 out of pocket. And so the $2,000 out of pocket, and for many carriers, they're opted with a plan that includes what the carrier is paying. So when the total expenses reaches $2,000, then they go to 0 co-pays. So that is the biggest change, I think. So the average has been for seniors where they're into the donut hole and hit catastrophic. It's usually around $3,200, $3,300. Now they're going to be going down to $2,000. But remember, this is only for prescription drug plans that are Part D as in David plans. It does not cover drugs that are B, the chemotherapy drugs, the special injectables that are considered B as in boy drugs. So those will not be included. And remember, always for the drugs to qualify for that $2,000, they have to be on the plan's formulary, or the plan has approved for them to be covered under their plan. So it is great news for the individual. That's the plus side. There's always an opposite side. And what that is that they have reallocated how the costs are attributed when the individual hits the 2,000. So you have all these drugs. It used to be 60% was paid by the drug company. Now it's 60% is paid by the insurance carrier, the company. So what does that mean? Higher costs to the companies. Therefore, higher costs to us as individuals, either as premium. There may be reduction in the formularies. The other action was they decided on some plans, especially the lower cost plans, they have elected not to pay agents commissions. And so that means that they're asking the insurance agents to continue to serve their clients and not be paid for servicing them. So it takes an hour and a half typically to really do a good analysis. So they've put a lot of pressure on the agents who still want to serve their clients, but they will not be receiving compensation. The other side of that, which makes it difficult, is under our errors and omissions insurance, if their carrier for that, it's kind of like risk insurance, like your home insurance, your car insurance. So what it's saying is we'll be running bare if we're not contracted with the company. Some have the clause that you have to be receiving commissions, some do not.
So they need to check and see what their agreements say then. So
every agent needs to check with their E&O carrier to see what their risk is, because if anything, the complaints and the grievances and the risk has been higher in the drug area. So it's kind of put the agents in a squeeze. They want to take care of their clients, but it's a real risk in some cases to do so. So a number of agents will probably say, oh, I can help you look at the plans, but you may want to go to Medicare.gov. So it's going to be tougher on the agents and our insureds, both from the standpoint, we have to look at what's your drug cost, what's going to be the cost for the carrier, and then can I enroll in that plan or not? So they're expecting 80% of the people may have to change plans this year.
Wow. So for the average listener that's not in the industry, for the Medicare recipients or their family members that are listening to this podcast or watching this podcast, can you summarize that in like one or two or three simple bullet phrases that for them to remember to pass on to their friends and families and loved ones that are 65 and older?
We can very simply say, this is the year you need to check your prescriptions against the formulary for 2025. And then you need to look at the 3 top plans that would give you the most savings, but to cover your drugs. That's the main thing.
Okay.
And so it's an important thing. It's not a year to be complacent. It is a year. I have thou shalts when I talk about Medicare. Thou shalt check your drug this year.
Yeah. Okay. Very, very good. Thank you. Well, can you please remind our audience what the annual open enrollment period is for Medicare and the difference between the annual open enrollment period in the fall and what they can do after January 1st called open enrollment? That sounds pretty confusing to those of us that aren't working in the Medicare field because it sounds like the exact same thing. But
and Medicare uses open enrollment freely in several instances. So just to be clear, we're talking
about
not just
me that's confused when they say that, right?
Oh no, I mean it's so we're doing the context of changing plans right now. So in changing plans, those who are on Medicare Advantage prescription drug plans, or many of them think of HMO plans, but in senior world, they're called Medicare Advantage plans. They could be a PPO style, or they could be the HMO straight MAPD. And standalone prescription drug plans, we have from October 15th to December 7th at that stroke of midnight to change plans. And it's the last application that's submitted that's the plan that'll be in force for January 1st. If you do not choose to change your plan and the plan is not sunsetting, they are closing some plans, then you'll just continue automatically onto your plan. That is called annual open enrollment period. I used to call it fall festival, like budget time when I worked for companies, that crazy time of the year we're trying to get budgets done. Right. Well, this is fall festival the same way.
Why don't they just call it fall open enrollment?
I know so open enrollment, and it's actually called open enrollment, applies only to Medicare Advantage plans. And those folks can make one change between January 1st and March 31st. Now, I want to add a little more into this going back to AEP. So annual open enrollment is also the time that people can transition from a Medicare supplement plan into a Medicare Advantage plan, and can go back from a Medicare Advantage plan into a Medicare supplement. But to do it on a guarantee issue basis, there's certain criteria that has to be met. They go back to original Medicare, and then they have to pick up a drug plan and a Medicare supplement plan. In the spring, or the deep winter, the January, February, March, people can go back to original Medicare. They can get on a Part D plan, but as far as having access to a Medicare supplement plan, in many cases, it may be underwritten unless they meet certain criteria. So it takes a little more work and a little more time to see what the options are, unless they're in their initial what we call their trial period, their first year of being on Medicare. So that's where an agent can really help them understand. And they truly do need an agent to work through all those if you want to do changes. But the main thing, as Dorothy says, the top bullet points is it is October 15th to December 7th for both MAPD and prescription drug plans. And then January 1 to March 31st is only Medicare Advantage plans. May change once.
Great. Thank you for that. And I do appreciate the summary at the end, because it's if it's overwhelming for me, and I'm in the industry, obviously I don't specialize in Medicare like you, but I'm just thinking if it's overwhelming for me, it has to be overwhelming for, the average consumer out there, Medicare beneficiary and so forth. So thank you for clarifying that. You kind of touched on this a bit, but what specifically can seniors specifically do during the open enrollment periods? You kind of talked about it, but can you tell us a little more in depth what they can do?
Yeah, basically it's really time to look. Well, set your priorities. As a Medicare agent, when I sit down, I always look at who's your doctors, what hospitals do you want to go to, what's your prescription drugs, and do you have any upcoming procedures in that, and where are you going to be having them? Because one, the formularies are changing. That's the list of drugs that the plan covers. Medicare requires that every plan cover 2 drugs in each major category of drugs. So every plan has a different list, and at what level, we call them tiers, just like we do in employer plans. Is it preferred generic, preferred brand, and then non-preferred brand, and maybe specialty drugs, maybe, they have insulin, which took place now that you can pay no more than $35 for your insulin shots. So we have to look at that to see, is the drug on the list of your plan? And it's not just as the drug, is the dosage. And this year we're expecting to see more as far as pre-authorization requirements, and step therapy may be required more in the plans. But that's the first thing the seniors need to look at. Also, we've had changes in doctors and their contracting over the areas. So it's a time to double check that your doctors will still be contracted for the plan. So we need to take a look at that as well. And overall, maybe your needs have changed. Are eyeglasses important? Is there care in the home you're needing? Are you traveling overseas? Do you need to have some coverage? So it's really taking a look at where you are. Because remember, we're looking at you for your coverage from year to year. This is not lifetime. This is every year we need to take a look to say what best fits your needs this year.
Right. Thank you very much for that. And again, you talked about this in the beginning, but what's new this year for Medicare recipients, and how do they know, how to prepare for the Medicare season?
There are so many exciting things this year. It's just amazing on what's taking account into the Reduction Act. Number one is the maximum out of pocket of $2,000. Number two is for individual who have higher cost drugs, and if they're over $600 a month for that specific drugs, the insurance company will be sending out an invitation to join the Medicare prescription drug payment plan. to where the individuals can even out their payments for the year. And it's only going to be offered through the insurance company. We agents are not being able to set this up. And the pharmacist will be notified by looking up on the plan and saying your plan is going to offer you the opportunity. You don't have to take it. So what it does is give even payments throughout the year. So you go to the pharmacy and then you're paying zero at the pharmacy, but you're paying the insurance company your monthly premium. So I'm talking about drugs like Jardiance or some of these and really expensive drugs that are over $600.
TV advertised drugs, probably.
Yeah. And so they would put the individual, they'd have an option to go onto the payment plan. So that's exciting. The other change that's taking place is they're changing for our Medicare, Medi-Cal people. This year in 2024, they could change plans every quarter. Now they're saying that if you are full Medicare, Medi-Cal, here in California, Medicaid and other parts of the country, that you can change monthly, but only to one of the integrated plans, the official plan within each county. If you're not, you're a regular Medicare, Medi-Cal person, full dual, and you want to change to a plan that's not one of the integrated plans, you can only do it over Open Enrollment Period, AEP or OEP, like the other Medicare Advantage plans, no more of this quarterly change. So that's a big change as well. Medicare has also mandated the insurance companies send out a notice in the middle of the year to remind people to use their ancillary benefits and to use a lot of their benefits, especially for things like colonoscopies, mammograms, and that, because they just find people are not using them and they want them to using them as well. Some of the Medicare Advantage plans may be changing their formularies because of that increased cost to them, but because of their star ratings and they receive higher amounts of monies, the Medicare Advantage people aren't going to be hit as heavily as the standalone people in that area. And there's more benefits for caregivers. There will be more mental health benefits coming into the plans. So we'll see some changes. There are, on a national basis, there are a number of Medicare Advantage plans that are withdrawing from the marketplace. And so there's going to be millions of seniors affected. We won't see that in California as much, but in rural areas, we'll especially see it, and maybe Northern California to an extent. So it's important to see, is my plan going to continue? There are going to be consolidation of plans. There are some plans that are going away. And so you may receive a notice for the individuals. Well, I think one of the most important things a senior can do, to summarize it, to look at your plan. Right now, they're getting copies of their annual notice of change. We call them ANOCs, annual notice of change. This is where it tells you what your plan is covering this year and what it'll cover next year. And it actually has a page by page, column by column comparison. And that you can go over with your agent, or if you don't have an agent, you can work with a company rep to actually go over those differences in plans. So I would say, number one, look at your ANOC. Look at your drugs.
Thank you very much. And what about the seniors? And I ask you this every year, but what are the most common questions that seniors that are, enrolling or looking to enroll in Medicare for the first time, what are the most common questions that they have?
Well, I think one thing that hits them is they kind of get confused about the payment of their Part B of Medicare. And this year it's $174.70 higher because of IRMA, the income adjusted ask. I always say that naughty girl, because we do, ever since the Obama Act, that's how it hit Medicare, is now those who have a higher income, and they do a 2-year look back. So if your income in 2023 is higher, for example, than $208,000 as a couple, you're going to pay more for your Part B. And they also add on for the Part D as well. So you get these little surcharges. So I think for the senior, one is to understand that will go up. That is your basic cost to participate in Medicare. You have to have your Part B, and you do pay that. What they don't understand a lot of time is if they're taking Social Security, it comes out of your Social Security. If you're not, Medicare is going to bill you. So that's number one. Number two, I think the thing is really taking a look at their doctors, saying who accepts Medicare, which is 92% of the doctors in the United States. And, you think, and the pesky areas sometimes are dermatologists and psychologists. So that's some area we have to watch closely. And then just understanding the drugs, the list of the drugs, and the fact that many times we have a deductible on some of the plans. And, if you're going on a Medicare supplement plan, you're going to have a separate premium for the supplement plan, and you have to get a standalone D. So sometimes I feel like I'm standing there with a fire hose. Just it's a lot to absorb, but after that initial time, they're good. And I always tell them, I said, it's looking at the plans is kind of like wearing a hospital gown. You're never quite sure what's covered. Yeah. And so that's what our job is, to help them really look at the plan.
Okay, great. Thank you very much. And thanks overall for just keeping us informed on, some of the basics, again, for newer listeners and so forth. And now video, I can't just say listeners anymore. I guess I have to say video watchers, I guess, as well. Mm-hmm. I have to keep remembering that. But let's turn now to what's new in Medicare. And again, at the beginning, you talked about this, but I'd like to come back and start getting into some more details. What can you tell us about the changes in Medicare this year? I know you touched on them earlier. Let's kind of get into that more.
Well, one thing I want to touch on that I haven't before, and this is for people that are involved in the group insurance world. So creditable coverage. It's time now for carriers to start sending out their credible coverage notifications. Been a lot of changes. Medicare has said they're changing how they're doing the Medicare credible coverage because of that change to that $2,000 max out of pocket. So they have a simplified version, how they do the calculations, and they have a complex version. So Medicare agreed to back off putting in the full actuarial one and allow plans to continue to use the simplified calculation. So what that means is the 2024 will continue into 2025. So it'll still be the simplified calculation. But for 2025, oh baby, it's going to be much more complex. And that's where for 2026, the changes on credible coverage will be quite a bit different on how they do the calculations. So why am I bringing that up now? Well, the reason is many times seniors who continue working on plans say, oh, happy to take my Part A. It's free. Why not? Because the employer plan will pay first and the Medicare will pay second. I really strongly suggest now, because of the changes coming in 2026, I would say to a working senior, we call them working agents, for the working agent people, do not take your Part A. Do not take it right now until we know what's going to happen in 2026 for credible coverage.
That's a scary thought when you say don't take it. To me, that's
right.
Scary.
Because you could be subject to penalties for your Part D, for your prescription drug coverage, because you didn't have credible coverage.
Right.
I forgot to mention the new Medicare and You booklet. The Medicare and You 2025 has just been released. Anybody who's going into Medicare, and for you folks who administer employer plans, get a copy of that book, because that'll tell you what Medicare covers.
Can you repeat the name of that again?
It's called Medicare and You.
Okay.
It's their handbook, Medicare and You 2025. It's on the Medicare.gov website. And the other companion book, for those who are in the companies, you need to download a copy of the book that says Who Pays First. Those are the two most important booklets. So if you're touching on Medicare world, those are the two books you should download and read. So it's Medicare and You 2025, just newly available. And then the Who Pays First books and all this information. There's so much in there that will help you.
Okay, great. Thank you. And you've talked about prescription drugs a few times today already, but can you just give us the latest about what's going on with prescription drug coverage under Medicare?
Yeah, I mean, to boil it down, the formularies are being changed. Mm-hmm. And so what a number of the carriers are doing are slimming down their formularies. They're pushing more towards the generics. Mm-hmm. So the more expensive the Part D plans, those plans are going up in cost considerably. They'll waive the deductible and to have the wider, larger formularies. The lower price plans, more the standard plans, will have the $590 deductible or maybe a little bit less. and the formularies won't be as robust. So it's an important time to look at the formularies and those type of things. It's a good time for some of these drugs. We may want to look more at manufacturing programs or a lot of the discount programs that are out there. The great news, though, is if the drug is on the formulary or approved to be covered, then they're only subject to that $2,000 max out of pocket. And so for seniors taking drugs that are extremely expensive, so Januvia is an excellent example. That drug is $500 right now. On most plans, it could be either $11 or $47, but when you hit the donut hole, you're paying 25% of $500. Next year, you're going to pay the copay until how many months to get to 2,000 with $500, 4 months, not counting all your other drugs. So you're going to be very easily. So that will be make quite a difference for a lot of seniors. The key is to make sure that the drug is covered. The other little hidden thing is there's been some changes on how Medicare is going to be covering some of those weight loss drugs and approve them some other things. So that's an area, if you're taking things like Wegovy and Ozempic and all of those drugs, the doctor will have some more options to take a look at. So that's for people on that, they need to really talk with their doctor and see, what's the diagnosis and how, because Medicare is working on that. So that's another whole area that we expect more news on, because it's proven to work, but Medicare does not cover weight loss drugs, but they look at it part of the condition. So that's something seniors need to talk to their doctor about.
Yeah, for sure.
Some changes in that area.
Right. Well, as you and I know, and a lot of people know, obviously the things we see on TV, the drugs we see on TV advertised are generally the most expensive or one of the most expensive in their categories. So I always tell people, if you can find something more, on a generic basis or on a formulary, do that, because obviously they're going to be a lot less expensive. But generally speaking, those are the highest cost drugs. So people should just be aware of that, whether you're a Medicare recipient or anyone else. I just think it's important to remind people of that. So tell us a little bit about the new prescription drug program, the Medicare Prescription Payment Plan. You mentioned that earlier. Can you tell us, about that? Who's eligible? Is it, standalone versus Medicare Advantage? Explain that whole thing for us. And then how do you enroll in it, and should they enroll in it?
It's an interesting program. It's really going to be administered by the insurance company. We agents cannot enroll people in it. The pharmacy can't enroll people in it. It's the carrier. So the way it'll work is anybody can enroll in it if they want to. But the reality is it's only if you have expensive drugs and you feel like it would be to your advantage to spread the cost of that expensive drug over so many months. That's what the program is designed for. So what happens is when the first claim comes in, when you go to your pharmacy, and they're all being trained right now this week and next, by the way, when they go to their pharmacy, the pharmacist will say, oh, do you know that your drug is this expensive? You need to contact your carrier. And when he hits the button, or he or she, it is going to notify the carrier. It's going to say, hey, this is an expensive drug. The carrier is going to send a letter or notify you that you are eligible for the payment plan. And the way the payment plan is, you can enroll typically through the carrier. Just give them a call. Probably, we're waiting to see how they're going to administrate it, but probably a phone call. And they'll set you up on it, and you pay the insurance carrier for the monthly payment, and they'll determine the payment. And if your drugs change during the year, the carrier will address the changes and bill you accordingly. But you'll be going to the pharmacy and you'll be paying zero at the pharmacy. But you do have this payment that you have to make to the carrier. Now, here's an important thing to know. If you don't make your payment plan, it does not cancel your original insurance. All right, that stays in place, but the carrier is the one who's billing this program. They call it the M3P program is their nickname for it. And so you're responsible to pay the monthly premiums. It's really great for people like, for instance, my husband's on 17 different drugs. His drug cost is expensive. It may work for him if we needed to level out those payments for the year. Yeah. And if you come in the middle, they'll adjust it for so many months. So So we agents cannot calculate it because it really depends on their drug use and all the drugs that they're using. So we can just tell you about it, but we don't administer it. We don't enroll in it.
Right. Yeah. Thanks for that. Another change this year is for people that are already on Medicare. I understand that Medicare may actually change their plans. What's that all about? And what are the changes? How will that work?
Well, the changes, again, it's annual open enrollment. It's when people can change, and it's the last plan submitted in. The application is a plan you'll have in January, and that's when you can change your plans. And so you can take a look. And as I mentioned, a number of the carriers are going to be withdrawing some plans. They're introducing some new plans. Coverage are changing. So it's really a time to say, what am I thinking this next year I really want to have? What's important to me this next year? So that's some of the things we look at. One little area people are not aware of is chiropractic is an area we have. If you're really into chiropractic care, I really have to look to see what it is, because is it Medicare covered or is it expanded coverage? And a lot of people don't know there's that little fine tuning area in there too. So that's an example of things we need to look at. Sometimes foot care is important to people. We need to look at the things from plan to plan. So, the meals, a number of plans are going to continue the meals. Grocery benefits may go away in a number of plans. So a lot of those added benefits may be reduced this year. Some, however, increasing their over-the-counter benefits. So it's a plan-by-plan change. Because remember, we've got that heavy Part D 60% hitting all the carriers that they have to make up the difference. So this is the year where a plan star rating, which is dictates how much money they receive from Medicare, and also not only the star rating, but if a person is diabetic or heart, as to how much money the plan receives so they can offer better benefits to people. So this is the year, because of the changes to the plans, this is the year the individual really needs to decide what's the most important thing for them for coverage and what's going to serve me the best for the following year. So no one plan is the best. It's what's best for the individual for the next year.
Right. That's why they need experts, people like you, to help them through that process. Not going to be that long until I turn 65, and I know I'm going to be calling you because I have no clue about this stuff. Like I said, I work in this industry, in the insurance industry and benefits industry, but that's completely different from your expertise, which is Medicare and everything involved with senior care. It's just, to me, I applaud you because it's just too much for me to deal with. I mean, I have so much other stuff with groups and, self-insurance stuff and compliance and all this other stuff. There are only so many hours in a day and days in a week. So I'm so glad that we have experts like you that we can talk to. Well, I know there are other updates. You and I have talked about them, and you mentioned a couple of them earlier on. But I'd like to provide our audience with some background on this. And you talked about things like the changes in compensation for producers. Can we talk about that? And specifically what I want to ask you on that is, and you touched on it, as I said, if the agents aren't getting paid compensation, are they going to be as willing? I mean, some agents, would they be as willing to help their clients and customers as they would have before if they're getting paid on? And might they sway them in another direction, maybe to a different carrier? That sort of thing. I mean, this has a lot of implications. Agents need to get paid for if they're doing the work, in my opinion. They need to get paid for it. Cutting the compensation is just a horrible thing because you can't expect people to work for free. And I think that's what the government is doing. And I think coming from the outside, I mean, somebody like you that says that, they could say you're self-serving. I'm not a Medicare person. I don't do this. And I'm saying, I think that when you start messing with the compensation of the people that are doing their best to try to help, that are holding their hands, that are walking them through every little detail, I know how you take care of your clients. And those Medicare beneficiaries, they're confused. They don't know what's going on. They're a little bit scared. They just don't like the administrative paperwork, and they're just afraid of their futures. And now they're talking about taking away compensation for that one good news that the seniors have, which is their reliance on their agents to help them through the process. So can you just comment on that? I know that's my personal opinion, and I'm sorry if you don't agree with me, but some of you out there. But I just it's to you, it's, if you say it is self-serving, it's not self-serving because I don't sell Medicare. But tell us about that.
Well, I mean, frankly, I have to earn a living. I mean, I have people that depend on me and yeah, I got to keep the roof here and going. So I need to be paid for my services.
Right.
And and here in California, under our AGIS contract, we're not able to charge on a consulting fee for a sale. And in some other states they can, so that's been mitigated. But here in California, we cannot. And in fact, if an agent is charging a consulting fee, that's illegal under our contracts. We cannot do that. We have a number of agents that say, I'm happy to provide guidance. So I'll tell you what to look at. Go to Medicare.gov. You can go ahead and we can see which is the best plan for you. If I'm not contracted the plan, I can't say, yeah, take that plan. I can say, here's the top 2 plans you probably want to consider and leave it at that. And then they can enroll through Medicare.gov. But people don't realize they're calling a call center.
Yeah.
It's a contracted call center.
There's nothing personal about that. There's no one helping you saying.
They don't care. Yeah, it's one and done.
The tone of your voice when you're saying, this is so important to me because they don't care about that. They
don't care. They'll put you on the plan. They'll be very warm and wonderful, but they'll get you on the plan.
Yeah.
And then the service for the plan, you're on your own for customer service. And that one carrier who says, oh, we're not going to pay commissions, guess where their service center is? Overseas.
Of course it is.
So you're dealing with very sweet people, but their experience is not that wide. So the difference is we as agents know the ins and outs, and the key is we know who to call for the problem.
Right.
You're dealing with customer service. There's a lot of good people in customer service at the companies. We'll never denigrate them. Hey, heck, I used to help train them. But how do you see the whole picture?
Right.
So we are taking and sending our poor people off instead of doing that. Personally, I figure if I have the Medicare supplement plan, they're still my client. And I'm still being paid to take care of them. I'm just not being paid for that drug portion, perhaps. They're still my client.
But you still took a cut in pay.
Yeah, but for people who want standalone Part D plans, and I have not, in the past, I've always been happy to help those people. Now I have to give it a second thought, because if I'm not being paid and they're only going to be Medicare Part D plan alone, I'm not sure I can take on that risk. I can't if I'm not contracted with the plan anyway.
And you mentioned also before that sometimes their errors and omissions coverage won't cover you.
Correct.
So that's something that's even bigger. That's bigger.
Yeah.
Because they have to have the errors and omissions coverage in place, obviously, to do their job. So I wanted to bring it up because, we do have a lot of audience members that are agents. We also have a lot, like I said, that are employers, and we very, very diverse and just everyday consumers. But I don't think people really understand. They have no way of knowing what's happening. They don't know what's happening with the insurance companies. Do you think that the insurance companies that are going in this direction, I know one already has no compensation for that type of plan. Are you guys afraid as agents in that environment, in that world, are you afraid that other carriers are going to look at what that one carrier did? They're saving money. Should we go in that direction? Are you worried about that?
Yes, we are. Frankly, there's many doomsayers that says that, frankly, that we may be looking in 2 to 3 years that agents are not compensated for Part D plans. So with the Medicare Advantage, probably will continue to be. That will be an advantage. So here, the pressure will be on more to do more Medicare Advantage plans as opposed to we'll still do the Medicare supplement plans. But even in the Medicare supplement plan world, they're reducing commissions in a number of areas for different situations. So there is a lot of pressure on the Medicare agents to provide service, and we're even more highly overseen. But they're actually reducing our commissions in a number of areas for service. Because remember, we're in that 15% of profit area, and that's what the companies. And I'll be frank, when the insurance companies were having their meetings this year, when they were meeting with their stockholders, many have said that their objective is profit over membership this year. And they have said that right out at their public meetings, is they're looking at profit over membership growth. And so before in the years, they've been saying, oh, we're looking forward to growing so many members and look what we've done. They're not doing that this year.
Yeah, at least they're saying it out loud. At least they're admitting to it. I mean, you have to give them some credit, I guess, for that. But it's just, to me, as a person from the outside looking in, I just think it's really sad. I think it's horrible that, because unfortunately there are going to be some agents that they're not even going to help them at all. Like you'll still help them because they're still your clients in another area and so forth. My fear is that there are going to be agents who say, I'm not getting compensated. Someone asks them a question. Sorry, can't help you.
No.
And what's that going to do to the Medicare recipient, the person that needs the assistance? And I think maybe I'll call for it today. I don't know. I don't know if it would help or not. Maybe we should get some sort of organized thing together that get the people out there to say to your congressmen and talk to your, if they are on the phone with them, hey, what happened to my agents being able to help me? I rely on them. Why did you take this away from me? And I think if they were hearing from the consumers, the Medicare recipients themselves saying, you took away a service that I rely on, that maybe they might make some additional changes to that in the future. I don't know. I'm just suggesting that maybe we get some people to start talking about that and to bring it up to you today, because I just think it's horrific that the seniors may not be able to get the assistance that they need because maybe perhaps their agent won't talk about it, or like you, because you have to worry about what you can and can't say and what you can help them with when you're not actually their agent for that particular plan. That crosses a lot of lines and just makes you feel a little uncomfortable anyway. But anyway, you've got rules and you've got contracts to deal with and things like that. So I just think that if this is important, if you're a Medicare recipient, if you're out there, you're a beneficiary, and you rely on people like your Medicare agent to help you, then you may, like I said, you want to make a phone call. If you happen to be visiting your legislators, talk to them and say, hey, why did you take this away from me? I want to be able to have my agent back to assist me with this stuff because it's important, and tell them why, and share some stories perhaps with them as to, how great your agent was to help you, and how other people that, maybe your family member that didn't have someone help them, what a nightmare that was, something like that. So think about, and I'm not saying don't lie, just tell us the truth. If you have actual stories, maybe you should share that with people in Washington and the carriers. Maybe they'll hear this cry, and maybe they'll actually start to reconsider that decision to do that. Profits, I mean, I get that profits are important for everybody, but when you're selling a product that is so important, I'm sorry if I'm getting emotional. I can imagine how you are. I'm not even selling this stuff, and I get emotional talking about it. You've got to be able to help the people that need it the most. So.
Oh, absolutely. And one thing, our association that Dorothy and I belong to, NABIP, is actually collecting those stories from agents so that we can, because they are actually meeting. I know I'll be going back in February. I meet with the Ways and Means Committee. I meet with a number of representatives in the Medicare side of the world, and we'll be discussing this. I think what you have to realize is some of this came from COVID times. They had over 41,000 complaints, and unfortunately, they don't separate the agent services from these telemarketing organizations. Medicare lumps us all into one lump. And so they're looking at us that we were bad, where, I'm thinking, you've seen those commercial on TVs. They promise this stuff. They move people. And so a lot of this is a reaction to that occurred during the COVID times. So we're still trying to educate CMS in a long ways with this. And it's a slugging work. Just to work with them, because you got to think these people don't have contact with the average individual. They're just looking at the statistics, and they're hearing the complaint side. They're not hearing all of the positive side. So that's probably a large part. And I want to reiterate, I mean, I used to work in corporate. Yes, you have to have profits to keep the company going. I'm just saying that you just need to be aware the companies are not targeting growth this year. I think that's the way. They are trying to stay solvent. They are trying to make sure they're returning monies to their stockholders. But, we're part of that 15% profit margin, and they've got to kind of think how they allocate. But we're also their marketing arm.
That's what I was going to say. What would they do without you? Because somebody has to sell this and service this and talk to the Medicare beneficiaries about it and explain how it works and so forth. So I just think it's very sad that we've gotten to the point where they want you to work basically for free. and work in an area sometimes that you can't because your contract won't allow you to, because you're not being compensated for it. That's, this is, well, I don't think this was very well thought through, shall I say. But
And the one thing I want to say from the association, the NABIP that you and I belong to, and many of our listeners here, we look at it not just for protection of the agent, but paramount is the protection of the beneficiary. And that is really our emphasis. And that's really what we're afraid of, is that we want the individual to have the best understanding and options. And all these changes are really putting a lot of that at risk.
Yeah.
That's, as you're saying, I agree with you, Dorothy. That's the risk.
Yeah.
Is to the beneficiaries.
I know you have you on the podcast at least last several years, every year, every fall. But this year I was actually very much interested in having you on because I wanted to ask your opinions on this because I just thought it was so important. Obviously, the other things we talked about were equally as important, but to me, this was something that, again, I'm not too far from 65, so I want to know that when I have to enroll in it, that I have somebody like you that can help me, because as much as I deal with government stuff all the time, I'm not a Medicare expert, and you go onto those government websites, and they're not easy. I know from personal experience because I work on doing all these filings for group and for all this other stuff. They're not easy. The average person out there who's not used to dealing with them, like you and I are.
No, and interpretation. And, I used to be in compliance. And I always tell my people, never call the insurance commissioner to ask the interpretation. A lot of people, let's call. No. I do have another little fun joke I always tell people when I'm working my seniors. I said, as long as Congress is in session, this is Mark Twain. He says, no man is safe. So this will change every year. So bright ideas, people are trying things. So we just have to do the best we can.
Yeah, I understand. Well, thank you so much, Maggie, for being with me today and for sharing all of your information and insights and so forth with our audience. If people want to reach out to you, which I'm sure they will, how would they do that?
Dorothy, the best way I think people can contact me is through my email. So it's Stedt. So that's M as in Mary, S as in Sam, T-E, D as in David, Tom, at StedtInsurance.com.
Great. Thank you very, very much. I just want to say again, thank you. I like I said, I love having you on every season, but this one was really important to me and to our listeners and to the industry as well. But most importantly, we want to help the beneficiaries out there that are getting ready to enroll or are already enrolled in Medicare. Well, thanks again for being here, Maggie. I really appreciate it.
Oh, you're welcome. Thanks for having me, and have great selling, folks.
Thank you. To everybody else out there, please stay safe, stay healthy, and stay tuned for the next episode of the Benefits Executive Roundtable. Thanks, everyone.
Thanks for all you do. Bye-bye.
Bye-bye.
Thanks for watching. Stay tuned for compliance tips, cost containment ideas, new trends, and decision-making tools. This podcast is produced by Advanced Benefit Consulting, Anaheim, California. All views expressed are those of the host or interviewees and not necessarily the views of Advanced Benefit Consulting. Information contained herein should not be construed as legal advice. We always recommend that you consult with your legal counsel as situations do vary. Ms. Cociu can be reached at 714-693-9754 extension 3 or toll free at 866-658-3835. By email at dmcociu@advancedbenefitconsulting.com or visit our website at advancedbenefitconsulting.com.